Welcome to my podcast. Today I'm going to talk about another common case can be seen in the clinical setting. Back home, I used to see these cases a lot. So basically, you have to introduce yourself, double check the patient name and date of birth. You'll ask the patient, how can I help you? And the patients seem to be like teenage or young people or middle age who will present with asymptomatic, possibly skin rash or mildly itchy skin rash. And the patient will say, I noticed this red patch on my neck or my chest. Or someone told them, like the spouse in the back, and they don't know what's that. And they have tried some OTC steroids, for instance, and it seemed to be with a little help. And they get panic when the rash progress over the past few days. And that's why they book to see a doctor in order to alleviate their worries and their concern. So you will ask, have you had any thoughts? What might be the reason for this rash? So the patient might come up with something. Say, for instance, if they visited a place or been traveling, or maybe they went to the beach, or they stayed overnight with a friend or some pets, and they will relate this itching or the pityriasis with that kind of thing. So you'll ask also if there is any recent change in the skincare or any product being recently used. The patient will deny. Also, you need to ask if they have any encounter, casual sexual act, or if they are in a stable relationship with a spouse or a partner or whatever. And the patient will tell you, I'm in a monogamous heterosexual relationship, and I don't have any history of sexually transmitted infection whatsoever. And even if you send them for that, it just turned out it's negative. So from that regard, you'll ask if there is any history of medical condition or a history of regular medication or any condition that they suffer with, and if there is anything similar in the family member, or if, any recent thing in that regard. And after that, you'll ask the patient, I'm going to have a quick look into the rash, and we'll take it from there. So after the patient agreed to be examined, and if it's a woman, and vice versa with the opposite sex, you will ask for a chaperone, of course. And on examination, you'll see a kind of a rash, which can be red or to violet, or mildly pinkish, oval in shape, and mildly scaled at the peripheral with something called colorate. And it could be anywhere. It could be either in the chest, on the neck, in the back. Could be also in the upper thigh, if it's inverse. And the patient will say it just progressed and just gave you like a festive distribution. In relation to the skin cleavage, or what we call aligning with the longer lines with peripheral scales. In that regard, you need to think about differential. So one of the differential you could think of is pityriasis rosea, which could fit with this situation. And the cause actually is not well known and unfounded. And some they had linked this to a viral infection like herpes 6 and 7, or influenza A, or as we know now recently, COVID-19. It could be related as well to drug triggers like angiotensin-converted enzyme inhibitor, or non-steroidal anti-inflammatory drugs, or antipsychotic, or in certain situations could be post-vaccination. However, the pityriasis rosea usually it's self-limiting. Some patients, they might not even complain of anything. They might be asymptomatic. And it will resolve within like 2 to 3 months. In general, it's 6 to 8 weeks. The other condition you need to think of as a differential is secondary syphilis. where the Herald patch is not there, it's lacking. However, the palm or the sole of the patient will be involved with the skin rash, which won't be, of course, in the pityriasis rosea. The other condition is pityriasis, where the scales, of course, and we all know, it's quite thick and silvery scales, and in that regard, usually it has a preceding post-inflammatory and upper respiratory tract infection. Patients usually, when they heal up, they might have like a hypo or hyperpigmentation, especially in the dark skin. And most of the treatment which being advocated is mild steroid or emollient. I remember I used to just give my patient emollient and they do quite well. Or antihistamine if the patient is complaining of too much itching. However, if its condition is very severe and it's not resolving, you could try like phototherapy or oral antiviral pills. I hope by that I cover one of the most common cases being seen, and I have seen a lot of those cases back home. And I don't know if it's common in the UK or not, but this is one of the cases you could come encounter in the clinical setting, and you just need to think thoroughly how you can perceive this case and treat it and take it from there. Thank you.